Hi, welcome to Human Capital Gains. Today we are joined by Geoffrey Roche. Geoffrey serves as the Senior Vice President of Healthcare Solutions at RisePoint, where he leads healthcare services business, oversees academic strategy, and manages the Healthcare Center of Excellence. Prior to RisePoint, he was the Director of Workforce Development at Stevens Health and Ears, leading national strategies to build a future-ready healthcare workforce. Geoffrey, thanks for joining us today.
Thanks for having me, Gary.
We're excited to have you here. Tell me a little bit about what you're doing at RisePoint.
Yeah, super excited, obviously, to join the RisePoint team. I have the privilege of working with many people in the higher ed space. Will know Dee Ranieri. She was the former chief content officer at Coursera, a longtime leader at Northeastern University, and she leads our academic and product team. I have the privilege of really working with our academic partners to really scale online nursing pre-licensure and nursing pathways across the country with our incredible clinical subject matter experts. And then also working closely with employers, hospitals, and healthcare systems to look at how do we drive academic solutions that ultimately become their learning and development strategies that focus on, recruitment, train to hire, retention around not just nursing, but all aspects of the healthcare trajectory.
That's really fascinating. Where are you seeing working with colleges and institutions their greatest need right now?
There's definitely a lot of need and a lot of assist, right? I mean, certainly we have to acknowledge there's a lot of changes, certainly on the federal side. And then, when you have those changes, we're also talking about an industry that has at times been not able to be as nimble, right? And so a lot of our work is critical to help them be more nimble, help them have that ability to be more agile, certainly help faculty to, take away the things that may not allow them to do what they do best, support the infrastructure, which I think is super critical. Ultimately, I'm a firm believer that in the healthcare space, we have got to build more scalable, impactful online education with the clinical experiences done in person. And a lot of healthcare has done this, but if you look at it, in many cases, outside of the large online institutions, it has not been as common. And a lot of it is really just fear over whether that online program will reduce your NCLEX scores or will have some impact on the accreditation end. But ultimately, it is the employer friendly solution. And I'll add, it's also the working learner solution. And so a lot of the work is also being done to help convince, educate, and inspire in those areas to realize there is a good way, and I would add even a better way to think about this for the future.
Yeah, I think working learners is a great point, and there's so many parallels to kind of like corporate education too. It's kind of like what are those essential skills that we need to drill down to that in a busy adult schedule need to be transferable and just in time education.
Yeah.
Something that you mentioned there about kind of increasing agility in an industry. I've had a lot of people on this podcast, and we talk about that with a lot of different teams across a lot of different functions that have been embedded kind of ways of working for so long. Coming to mind immediately is kind of like finance teams, right?
Mhm.
Finance teams have done it a certain way. They're being disrupted digitally now. So agility to maintain relevancy in the industry is really important. How do you drive agility in the healthcare industry?
You really drive it with that employer lens, right? I mean, one of the things that I regularly talk about, and let me just say to your point on like corporate training, I regularly will say that like corporate L&D, where we've taken kind of a one size fits all approach and thought that would work for an L&D strategy, yet not recognizing we've got five different generations in the workplace, and that learner learns differently. It's similar to higher ed. In higher ed, we've had a 100, 200 plus or longer approach to how we educate. And I'm not suggesting here that institutions are choosing to be behind the times, because I know there's infrastructure, there's resource constraints, but you can't teach learners today how we taught learners in the past. The modern learner is very different. How we approach in every facet is different. So in the healthcare space, which I will say, in my humble opinion, it's the most unique space in all of education. It's also a space that I love the most. So it's a space I only really care about. But reality of it is, it's also the most challenging space because we have licensure, we have accreditation, and 9 times out of 10, when it's a licensed program, an accredited program, has all those complexities of compliance and risk management, there's just more concern over will if this decision is made cause this. And ultimately what we have to come down to is bringing that employer voice in. I have seen phenomenal success at academic institutions when the employer voice is there. I've seen academic institutions who have tried to innovate with accreditors, with licensing boards, and got shot down. But when the employer is at the table and the employer says, no, I need this and I have confidence in how we can do it, I see much more solution-oriented approaches move forward. And so I can't stress enough that piece.
Yeah, and I think that's applicable to just about every industry. In finance, we're seeing the same thing. The more that you can actually get people in the workforce and practitioners to speak about the needs, and especially when you're working with academic institutions, often they're not in the market. They don't understand, the changes and the complexities that these companies are feeling every day, and how that they need a ready and able workforce as they leave their education to be able to make direct business impact.
Yeah, and I'll tell you, having spent, 2+ years at, one of the largest global med tech companies where I got to spend, time over probably nearly 30 states or more, visiting hundreds of academic institutions and hospitals and healthcare systems. Ultimately, like you and I were talking about before we got on here, truly immersed versus consulting, but I was truly immersed, connected truly in the work that these institutions and organizations were doing. What comes down to mind for me as I think about it is this is really all about workforce transformation. And we've got to be able to transform both the academic side and then also the industry side. And I've long thought, even back when I was a hospital administrator, that the difference in this space is really the difference of operating with a partner in a more transactional way versus really operating in a more strategic manner. And once you get to that strategic relationship where you realize that we need each other, we're symbiotic, what we do together, we succeed or we fail, is a much different situation than that transactional. And I have long thought in healthcare, it's been too transactional as it relates to this work. And the more that it becomes strategic, everything changes.
Do you see a willingness from all parties within that strategic partnership to align in a meaningful way? I know that you said that once you have a corporate sponsor or an industry sponsor, that those processes move faster. I'm interested when you're talking about kind of oversight and governing boards, realizing that maybe some of their requirements are a little antiquated, but a lot of those requirements are tied to legislature within states. How do you circumvent that when your corporations are saying, listen, this way doesn't work for us anymore? So it's almost, you have to convince the learner or the employee that, hey, you need to do this to check that box for your state requirements. But then we really need to move the needle. And you're essentially asking them to do almost double the work to make sure that you're actually moving the needle for the industry. How do you find that there's a balance for that? And do you get any pushback from the end users?
Certainly there can be. In many of the examples that I can think of, in many cases, certainly there can be legislative or more governmental challenges for sure. But in healthcare, most of the time when we're dealing with these things, it's actually more at the accreditor or the licensing board level. And that there could be more of a political fix to some of that. Generally, it's more, we've always done it this way. And that is really where having the employer there to explain that's just not how we do it today. So I'll give you an example. There's a phenomenal healthcare system in Wisconsin that ran into this in both nursing and in respiratory therapy. And that employer worked with their academic partner and went to the accreditor in both cases and said, here's how we would recommend we do it. We understand your current structure of accreditation wouldn't allow for it. We as the employer feel it needs to change. Here's what we would do to change it. And in both cases, the accreditor said, wow, love what you're doing, green light. I don't think that happens enough. Now, you will also hear me say from work that I did at Siemens that I also very much believe that there is, and I know some people when they hear this will say, oh boy, here he goes. There is overreach in some of the accreditation aspects, for sure. And I think, as I've said to accreditors in meetings with them directly in the work that I've done, we need you to spend time in industry just as much as you spend time accrediting academic programs. And if you don't, bring industry voices into your process, because we have to make sure we're dealing with today, but also the future. So when we talk about building a sustainable future-ready healthcare workforce, we can't have standards that were developed in the 70s, 80s, and 90s and still stick on those standards when the reality of it is the workforce has changed, the people we serve has changed, and frankly, those standards are inhibiting us to be able to grow a workforce, and yet those same standards still sit in place. And so generally and I'm not suggesting these people aren't well intentioned. It's generally they had these things at a time when they needed it. Times have changed, and we need those people to move along with these changes because it's most critical for really sustainability. My biggest concern in healthcare is we could come to a day, we do at times even now, where you think about ORs. ORs have shut down across this country just purely on we don't have enough staff to be able to run them. That's not a good situation. Now, in those cases, that's a lot of elective surgeries. But again, for people who have to wait for an elective surgery, still not a good situation. My fear is, do you get to a point where the more crisis oriented, the more emergent situations, you don't have that, then we're talking about a much different situation. We can never be in that position. And the only way not to is to really be bringing that employer voice into this.
Yeah. From the accreditation side, it's really interesting how often that seat of neutrality turns into almost a throne of control. And like you said, well-intentioned often, but mired in institutional legacy rather than forward thinking. It's interesting that you bring up kind of ORs. My mom is a former OR nurse.
Sure.
Was for 30 years. For a while, she missed it so much, she went back. And it was funny because she always joked, everybody in the OR is just as old as I am when she went back, because it's the older generation that just kind of that stayed there. And there is a pipeline play. When we talk about pipeline for healthcare, there's always a nursing shortage. And, we're constantly seeing, a kind of crisis of available healthcare workers. What work are you doing to kind of help and ameliorate that?
Yeah. Well, obviously we talked a little bit about the work that we have to do to scale more programs online with the in-person clinical placement piece, augmentations with very robust, strong, innovative simulation. There also has to be a lot more work done, as you and I were talking about earlier, around really K through 12. We've got to also educate individuals about why and how these roles are critical. But even beyond that, I, very much strong believer, even when I was at Siemens, a lot of my work started in this space around the strong movement in the US to move more towards a apprenticeship degree option. I do believe very strongly in the nursing space and all aspects of healthcare. This is a model that has to be moved to. In fact, we were talking earlier about travel. When I'm in the UK, it'll be a global convening on apprenticeship degrees. The US is so far behind in this space, but I'm encouraged because obviously both the Department of Education and Department of Labor in this current administration do have some individuals who very much are proponents of this work. We have got to move some of the accreditors and some of the licensing boards along in this space. Work-based learning matters. You can learn and earn on the job successfully. And in fact, I would argue your clinical professional will be only that much stronger. I've met these students that have gone through apprenticeship degree programs, both in the US, in healthcare, and globally, and I know it. I've seen the data at a UW Health in Wisconsin. They've got 2 apprenticeship degree programs running, phenomenal success. And, we've got to move to this more scalably, and we have to be able to support other academic institutions to do it. It has to happen at all levels: community college, 4-year privates, 4-year publics, because we got to make sure there's still equitable access within all those facets. And I'll add, for learners, it's the best situation because guess who's paying for that education? The employer. And guess what improves? Retention. And so that's certainly a lot of the work that we will be doing as well.
Yeah, I love that. I think the apprenticeship gap that we have here, as we talk about kind of like current onshoring efforts, we're having a lot more conversations about how we can support apprenticeship programs in a lot of frontline industries. And a lot more people are coming towards us asking for that support, which is really, really interesting. You're absolutely right. We have to move the needle on that in a lot of industries that are seeing issues with staffing or issues with pipeline. We also see a lot of efforts as we talk about AI, replacing jobs. And it's, the quote unquote kind of like blue collar or hands-on jobs that are often mentioned there. But I don't think a profession like nursing is mentioned enough as kind of like a stable economic driver. How do you see AI? We can talk about impacting jobs, but I also want to see, how are you seeing AI impact career paths within nursing, and how are your programs kind of reacting to that?
Yeah. So the first thing I'll say is At the end of the day, the most effective thing we can do with regard to AI in healthcare is to make sure the clinician voice is at the center of it. Because ultimately, we have a habit in healthcare of rolling out technological solutions without ever actually asking the end user what and how it should be used. We've done it with electronic medical records, we've done it with computer entry systems. I mean, we could just go on. And so we've got to make sure their voice is at the table. I do believe you raise a really critical point. And that gets to the fact that as we think about digital transformation, we think about AI, we think about all these new ways, what we have is a significant challenge in the healthcare space because our faculty have not necessarily been educated, upskilled to prepare for all of that, to be able to impart that knowledge and expertise among our students and among our learners. And so that's why one of the reasons I strongly believe in the apprenticeship degree is we've got to flip that model. So, when we look at other countries that are doing this, they understand these things, they perfect these things more because they're actually on the job, in the job, using the tools, the technology, and learning. And that's where we have to flip it. We've got to have more of the learning occurring in industry with faculty there as well to support this. Certainly in healthcare, AI, as we all know, is in a lot. But one of the things that I think we need to do, particularly in nursing, is leverage AI to get rid of the inefficiencies that truly create more burdensome burnout and challenges for our nurses. There are so many things that our nurses do that, frankly, they should not have to do each and every day. And AI and technology has to be leveraged to drive solutions in that space. We need to help our nurses with all aspects of self-care and really preserve them because they're incredible resources and they are the largest workforce of every hospital and healthcare system. Yet we're burning them out. And in many cases, we're burning them out with our own tools because we haven't asked them what's needed and we haven't acted upon it. And so a lot of work has to occur in this space. And I always say, we can educate all we want on the higher ed side, but if they then get in there and they're not seeing, we lose them quick. The average nurse today is much less than we've ever seen before. We can't afford to educate a nurse for 4 years or 2 years and then have them work for a year or two and then they leave nursing, either leave the hospital or leave the field as a whole, just because of the infrastructure there. That's the stuff that gets me very concerned.
Yeah. We are speaking with a lot of companies right now about AI implementation, and the pattern that we see across the board is there's a large spend. You never really kind of evaluated your workforce for where they need AI implementation to help them.
Mm-hmm.
So you have this large spend, it sits there for a year, nobody's using the AI as it was intended, or you're not seeing the gains to the bottom line, the ROI that you anticipated, and you're saying, hey, let's train the staff and fix this. We're working with a large healthcare provider right now that implemented kind of their own EHR system rather than, they kind of built it themselves. And, they're frustrated and questioning why the doctors don't like it, right? And they're asking for us to deliver training, right? Deliver training because that must be the problem rather than saying, hey, you didn't develop this with the actual end user, right? And that's what we're seeing with AI as well. Companies that are seeing a return on their AI investment are spending on average 70% of that budget on people and process first, right? And establishing actually where the need is, right? And in healthcare, I feel it's the same way, right? If you're not designing with the end user in mind and implementing those AI solutions, not to necessarily drive more efficient billing, but maybe more efficient people, so nurses can actually focus on what they got into the profession for, which is taking care of people, right? Delivering better patient care, providing better patient outcomes, right? Let's create some AI that helps them chart, right? That's taking all of those activities that are creating inefficiencies across systems.
100%.
Yeah. Where are you seeing kind of education wise the greatest kind of need and the greatest impact to what the employers are looking for, that impact to the bottom line? We're having more and more conversations every day. It's kind of okay, if we do this, how is this actually going to strategically impact the business? In healthcare, where are you seeing willing to make that investment to really kind of drive the business impact?
I'll say that I'm super encouraged here from the vantage point that I'm seeing more and more healthcare systems really understand that the long game of workforce development has significant return on investment. And what I mean by that is that the systems that are going deep, and really investing in early career models, youth apprenticeships, career exploration, all the way to apprenticeships to, career stackable opportunities from allied health, upskilling them into nursing or other roles, respiratory therapy. Systems that are really getting creative and strategic about real strategic workforce development are seeing tremendous return on investment. Now, sometimes that return doesn't happen as quickly, but when it happens, it will be significant because we also know the retention levels will be so much higher. And so that's definitely a space that I'm seeing. I also find that to be the only sustainable way to best plan for these things. Now, I will say on the clinical space, the one area that still has me greatly concerned, and frankly, I'm always sort of puzzled why no one has figured out a solution yet, is really the clinical placement and experience. That remains a significant bottleneck. I believe it's both responsibility of both the academic side and the hospital and healthcare system side. And there has to be some way of some solution to come in and help to make this a much better, efficient, more effective process. Obviously, one of the challenges is we lack clinical educators. And so, that adds a lot of complexity here. And also, we don't have a system that's as willing to lean in as much as the UK system is, for example, on simulation. So we've got a lot of complexities, but I still hope at some point we'll see more solutions in that space.
I think if there's anybody that can figure that out, Jeff, it's going to be you.
It's got to be me with a lot of other people because, as my colleagues know, I am not an operational person. Definitely try to stay on the strategy side and really the kind of thinking about the next opportunity side. But we have to, I've long believed, Gary, that healthcare in many ways, we have created our own problems. And there's a lot of great people in healthcare. And I think if we bring them together, with the great people in academia, just like the same, we can solve a lot of these things. It's just a matter of to our earlier comment, be mindful of, don't just go out and bring, a large consulting firm in, bring real subject matter experts in. Let's partner and collaborate, leveraging that power and that ingenuity. That's why, I'm fortunate to have a team, at RisePoint that are subject matter experts that are all DNP trained. They've been at academic institutions. They've also worked on the hospital side. That's who I want to work with academic partners and healthcare systems to ensure there's a seamless transition to clinical practice. I don't want to look at just data to determine that. I really want to make sure it's done by experts. That's what we have to get back to.
Yeah, it's bringing in a strategic partner that will follow you from strategy to execution, that will follow the course for you and make those micro adjustments that are needed throughout your trajectory to make sure that you're seeing the impact and finding the results that you want rather than just making a recommendation and walking away.
Exactly.
Yeah.
And the whole recommendation of walking away doesn't work anymore, right? I mean,
No.
we're sitting at, especially when we talk about these issues, I mean, we're sitting at truly the worst time we've ever sat at. It's not a time for recommendations. It's really a time for action. And so, and we've got to try things. And if we fail, we get right back to it. We learn from it. We get right back to it. This is not a time for recommendations. This is all about, we've got to act.
Yeah. Yeah. Fail fast and figure it out and make dramatic strides.
Yeah.
Well, I thought this was a great conversation, Geoffrey.
Yeah.
I look forward to our next one. And I just wanted to thank you for being here today.
Absolutely. Thanks for having me.